So good morning, good afternoon once again, colleagues, and thank you for joining our AMR CoP session today, the second in the month of August this year. We hope our AMR CoP session has been a significant benefit to you and continues to benefit in our collective AMR. Kindly mute your microphones if you don't mind, please. Thank you. Welcome once again. My name is Raymond Fachu, and I'll be your moderator for today. Kindly note that there is interpretation service from English to French available in this session. To be able to access this service, find the globe icon at the bottom of your screen. Kindly click on that and select your language preference so you can enjoy the full benefit of this CoP session. Today we have as our theme, Advancing AMR Surveillance for Public Health Action. In this session, we will discuss the worrying AMR pattern observed in children under 5 years old in one region in Ghana, and its implication on Ghana's AMR National Action Plan implementation. We will also explore in the second presentation strategies adopted by Uganda to support AMR surveillance and the role of country antimicrobial resistance coordinating committees in converting AMR surveillance data into actionable items. Within the 1 hour time duration, we will have Mary Magdalene Osei, who is a principal research assistant and PhD fellow in the Department of Medical Microbiology, University of Ghana Medical School, sharing with us on alarming levels of multi-drug resistance in aerobic gram-negative bacilli isolated from the nasopharynx of healthy under 5 children in Accra, Ghana. We will also have Mugerwa Ibrahim, Program Officer, AMR and Global Health Security, and Secretary to the National AMR Subcommittee, Uganda, also sharing insights on integrated interventions to AMR control in human health, the Uganda experience. It is really a pleasure to have all of us here, and we hope you all benefit fully from today's session. Colleagues, I will hand over to Mary Magdalene Osei for the first presentation. Thank you.
Good morning, good afternoon, colleagues. This is Mary Magdalene Osei, a research assistant with the University of Ghana Medical School, Department of Medical Microbiology. Presenting on alarming levels of multi-drug resistance in aerobic gram-negative bacilli isolated from the nasopharynx of healthy under 5 children in Accra, Ghana. The presentation will go through this overview: introduction, study objectives, materials and methods, results, discussions, conclusions, limitations, recommendations, and references. Nasopharyngeal bacterial pathogens, including both gram-positive bacteria and negative bacteria, constitute the primary ecological reservoir and source of dissemination of microorganisms such as Streptococcus pneumoniae, Haemophilus influenzae, Staphylococcus aureus, Moraxilla catarrhalis, as well as gram-negative bacilli. Asymptomatic nasopharyngeal carriage of pathogens is prevalent in infants and precedes the development of invasive diseases. This may lead to development of lower respiratory tract infections, including pneumonia and bronchiolitis in later life. Children in daycare centers may be important vectors for horizontal spread of respiratory pathogens. Hence, since they are reservoirs They can mostly transmit pathogens, including antimicrobial resistant producing genes. Research has shown that infants are susceptible to a lot of pathogens and hence play a fundamental role in the epidemiology of respiratory infections. Previous studies in Angola, Brazil, and Netherlands shows that prevalence carriage vary from 5% to 57% in healthy children. Currently, there is no published evidence on nasopharyngeal carriage of aerobic gram-negative bacilli from Ghana. Hence, this study will help to bring information which is crucial to help in understanding the common aerobic gram-negative bacilli prevalent in Ghana, and will also serve as an important baseline for monitoring for future trends. Hence, this study objectives was to determine the prevalence of nasopharyngeal colonization of gram-negative bacilli, and also to describe the common organism isolated, their antimicrobial resistant patterns, including multi-drug resistance, extended spectrum beta-lactamases, AMRCCs, and carbapenem producing gram-negative bacilli among healthy under 5 children from selected daycare centers in Accra metropolis of the Greater Accra region from September to December 2016. The study was a retrospective cross-sectional one involving 410 frozen samples at -80 in tryptic soy, skim milk, glycerol, and glucose, which is STGG stocking medium, which were previously collected to conduct a study in 2016 for pneumococcus prevalence and its serotype distribution among children under 5. Random sampling was made from 7 daycare centers from 4 districts in the Accra metropolis. The inclusion criteria for the previous study was children that have been vaccinated with pneumococcal vaccine, and children excluded were those who had no approved consent, children who declined to be involved in the study, children with active respiratory tract infection, and children who were on antibiotic use. The 410 nasopharyngeal swabs stored in STGG were brought out and stored, and a drop was placed in tryptic soy broth and incubated overnight. A loop full was then plated on makonke agar, which has crystal violet dye and bile salts to halt the growth of other gram positives, but rather encourage the growth of gram-negative aerobic gram-negative bacilli. This was put in 37 degrees Celsius incubator for 24 hours. Afterwards, gram stain and colonial morphology was followed, and those that came out to be gram-negative bacilli were then put on nutrients agar, and Malditov was used for identification. 0.5 McFarland stability was prepared for antimicrobial susceptibility testing using Muller-Hinton agar, and the 0.5 McFarland prepared was seeded on the sterile Muller-Hinton agar to obtain confluent growth, and was incubated for 16 to 18 hours at 37 degrees Celsius. All the antibiotics that was used for the study were controlled using ATTC control strain 25922 control, and the phenotypic resistance strains that were observed for ESBL ceftazidime, clavulanic acid. This combination was used to check for ESBL. For AMC, for phenotypic observation, cefoxitin was used. For carbapenemase, all isolates that were meropenem resistant were subjected to modified Hodge test to confirm carbapenem producing genes. All zone of inhibitions were interpreted using CLSI 2021 version. The data was entered in Excel sheets and imported into Stata version 14.1 for analysis. The antibiotics used were selected according to the standard treatment guidelines for the Republic of Ghana through the Ghana National Drug Program, and also WHO Aware Antibiotic 2021 classifications for children. 14% carriage prevalence was observed in this study. The organism prevalence were E. coli, Klebsiella pneumoniae, Enterobacter cloacae, Serratia marcescens, Acinetobacter baumannii, and Pseudomonas aeruginosa. E. coli had the highest prevalence of 26.3%, followed by Klebsiella pneumoniae, 24.5%. Pseudomonas aeruginosa had the least prevalence of 7.0%. Resistance was frequent. Resistance was most frequently observed for cefuroxime, which was 73.7%. Most of the organisms were least resistant to gentamicin, amikacin, meropenem, and meropenem. 66% was observed for drug resistance of the isolates. Multi-drug resistance was relatively high among Acinetobacter, Enterobacter cloacae, and E. coli. Acinetobacter had a high 100% multi-drug resistance in this study. For phenotypic identification of antimicrobial resistant producing genes, E. coli was high in ESBL with 33.3% and low in carbapenemase for 10.5%. Klebsiella was high in AMC producing resistant genes, which was 28.8%. Acinetobacter baumannii had 100% AMC producing genes. As stated earlier, this is the first study conducted in Ghana. Reporting on this prevalence and their resistant patterns is one of the information that has been gathered for this study. For previous studies mostly conducted were mostly targeting gram-positive bacteria and anaerobic gram-negative bacteria. However, this study showed other organisms like gram-negative bacilli, aerobic gram-negative bacilli, which can also colonize the nasopharynx. Hence, this evidence was limited because most research focuses on gram-positive aerobic and gram-positive bacteria and anaerobic gram-negative bacteria. Hence, this research will contribute immensely to the global limited evidence on the issue. 1 in 7 children were carriers of aerobic gram-negative bacilli. E. coli Klebsiella pneumoniae, and Enterobacter cloacae were the commonest organisms that were encountered. And then 2/3 of these organisms were the commonest organisms that were encountered. Resistance levels were high, and 2/3 of these organisms exhibited multi-drug resistance. I'll conclude by saying this research study calls for a nationwide surveillance system for periodic data collection, which will eventually help in generating a national representative information that can be used to inform the choice of antibiotic in empiric treatments of infections caused by gram-negative bacilli. It also calls for better infection prevention control at the daycare centers in Ghana for prevention of further spread and transmission. In this study, some of the limitations observed were sample size was not sufficient enough to estimate the resistance levels in individual bacteria. And the study was conducted in an area in Accra. Hence, the findings cannot be generalizable nationwide. Recommendations are that since this study reflects 6 years ago, it is very important to have a follow-up study to assess the current rates of nasopharyngeal carriage and resistance levels in healthy children. And also, it calls for a nationwide study or strengthening surveillance systems to routinely capture the gram-negative bacilli carriage rates in children. It will be very important to set up sentinel sites to collect nasopharyngeal swabs periodically, which will be used to analyze using molecular techniques. And this will help us to know circulating genes responsible for antimicrobial resistance. Also, it is very important to set up prospective follow-up studies to find out risk factors or factors that may be associated with progression from carriage to infection. High levels of gram-negative bacilli carriage and multi-drug resistance also call for a proper infection prevention control in daycare centers to prevent further transmission. In the fight of AMR, the way forward is that this study was in line with the strategic plan objective in the Ghana National Action Plan on AMR, which sought to develop and implement infection prevention and control policies and interventions in all relevant sectors nationwide, including schools with the daycare centers too. It also sets research agenda into AMR in affected sectors, including the daycare centers. It's also sought to establish a surveillance system for antimicrobial resistance, which is a recommendation from this study. And also to increase national awareness of AMR, which is using a platform like this to educate people and also use the media platform to also educate the public on AMR use. And it is also the fight for we, the scientists, that anytime we go for data collection for surveillance and for sample collection for our research, we should always make sure that we educate the public on antibiotic use and misuse. The WHO structured operational research and training initiative through this research will help to formulate infection prevention control policy, which will target the daycare centers or early childhood development centers and will be used nationwide to help prevent AMR. I will end by saying that the fight for AMR is a fight for all. These are some of my references. I would like to use this opportunity to thank WHO and SORT-IT program for mentorship into establishing this research, and for University of Ghana and the Department of Medical Microbiology for also their mentorship. I would like to also thank ASLM Academy and PATS for building capacity for training lab professionals. And to also thank USAID and Fleming for building capacity into infrastructure to build our labs. And for EQA Africa for helping us to be able to put our laboratory work into standard. Thank you very much.
Thank you very much, Mary Magdalene Osei. That was a brilliant presentation. We will move seamlessly to invite our colleague, Mugerwa Ibrahim, who would share with us on the integrated interventions to AMR control in human health, the Uganda experience. Over to you, Ibrahim.
Thank you very much. Good afternoon, good morning, and good evening to all, wherever you are in different time zones. Like introduced earlier, I'm Ibrahim Mugerwa, and I work for the Institute of Department of National Health Laboratories and Diagnostic Services. Yeah, my presentation will walk through the surveillance system, the National Microbiology Reference Surveillance, and the Sentinel site design, the data analysis, the challenges and recommendations, as well as in data analysis, different aspects of what methods we use to implement AMR at national level. Yeah, so I'll straight away drill into the governance bit of the strategy of antimicrobial resistance, where we have the National One Health platform. And then in the One Health platform, we have the Uganda National Antimicrobial Resistance Committee. And below that, we have the 5 strategic technical working committees, which translate into the 5 strategic objectives of the National Action Plan. So this is how we have designed the national surveillance for antimicrobial resistance. However, this slide underscores 2 technical working committees, the stewardship, optimal use and access, and the surveillance, as the ones which are more directly involved. The lab is more directly involved in regards to implementing the National Action Plan. And it is in direct with the strategic objective 4 of implementation of AMR surveillance for evidence-based policy and practices. Now, these are the objectives that we put in place as the National AMR Coordination Center within the Department of Labs in Ministry of Health. Number 1 is to establish a robust system for supporting and coordinating AMR activities in laboratories with the guidance of the technical working committees and the national subcommittee you saw previously. And then to have a well-functioning AMR AMU surveillance system within Human Health Ministry with established terms of reference for governance. And lastly, to establish a MOH-led system for collecting, analyzing, reporting, and disseminating of AMR and the MU data at national level. You realize that for you to do better surveillance of resistance, you must factor in the aspect of use and consumption. So if you don't have those, you may have challenges with your surveillance. We have strength. This is not reinventing the wheel, but we have strengths which are ideal for enabling surveillance as low-hanging fruits. We have the governance structure we've seen. We we have a phased manner of a sentinel site surveillance implementation, whereby we have all regional referral hospitals enrolled onto the surveillance system in a phased manner. And then we have the National Microbiology Reference Lab, where I belong in the department we work in, which lab has been CAP accredited. And then we have trained national pool of mentors. This able to do the TOTs at national level and a team of microbiologists to mentor lower sites. This is capacity building. On top of that, we have been supported by partners, that is Fleming, country grant 1, and another cohort is ongoing for fellows. And then 80% of our sentinel sites are enrolled onto the national EQA program. This program is geared, coordinated by the National Microbiology Reference Lab. We have developed basic tools, the lab registers under the HMIS reporting patterns. We have conducted the national microbiology supplies and consumption quantification. We have costed and projected the use and consumption of the supplies. And on top of that, we have the indicators to enable us link surveillance of resistance to use and consumption. And then we have a well-established and functional AMR National Coordination Center. And then the partner support. We have realized support from CDC, Global Health Security, Beta Uganda, and GHSA. And then implementation of AMU and AMS in 2 general hospitals, still by partner support. And then the Fleming Fund Country Grant 2. This is IDI, the Infectious Disease Institute, supporting us in the 9 regional referral hospitals. And the capacity building framework for regional Fleming Fund, the QAS, the MAPS, AMR, ASLM QAS. And then we also have a seed grant from Wellcome Trust Pfizer to support new sites like Chirudu and another addition one in Mbarara for AMR. This is the strength we have. Now, let's go into the dynamics of resistance. If I will not dwell so much on this, but if you are aware about the GRAM study, Global Research on Antimicrobial Resistance, which underscores antimicrobial resistance to be the leading cause of now the death, as most deaths are attributable to AMR, higher than even HIV, AIDS, and malaria. You realize that in 2019, 255,000 deaths in sub-Saharan were due to AMR, and then 51,000 in Western Europe, 389 in South Asia, and 84,000 were children under 5, etc. You could find this data in the Lancet. So resistance is particularly high for multiple classes of essential agents, like the beta-lactams and fluoroquinolones. Now, this is how we have designed our sentinel surveillance study. On the other side, we have the map of Uganda, and we have the regional referral hospitals, which serve a number of districts that make up the health region of that part, where a regional referral is able to serve those districts. And then the laboratories there, after working out all the essentials for AST and microbiology culture and sensitivity, they send their samples, isolates, in a system that was established by government to the National Microbiology Reference Lab. And then there you find the NCC and within the Department of National Health Labs. The other side, these are isolates referred for QC, validation, and quality assurance. The data we are going to see is from the isolates obtained from patient samples, like I've showed you. We looked at over 5,000 isolates. And then to underscore this, we looked at sterile samples, samples obtained from the sample, for isolates obtained from samples that were obtained from the aseptic measures. For example, the blood culture, for example, the pleural fluid, the CSF, and all those things. And then we focused on 6 commonest pathogens from these sterile sites. you look at this, this is how the average percentage agreement with isolates confirmed in terms of years from 2018 to 2019, 2020, sorry, with a percentage agreement differing. Then sites with 0 scores did not send any isolates. This means that these sites had not been enrolled on the national surveillance system. Now, detection of AMR sorry, I beg your pardon. Now, detection of AMR resistance, I borrowed this slide from one of our core partners in the Fleming Fund, that is Infectious Disease Institute, from the country grant. We work with them to do surveillance, to implement testing microbiology in the regional referrals. You look like that selected pathogens you see here, E. coli in 9 regional referral hospitals, E. coli in Mulago, which is a national referral hospitals in specialized clinics, and then Staphylococcus at 9 regional, and then Klebsiella pneumoniae at Mulago. You look at resistance patterns of the commonly available antibiotics as per classification of the WHO aware categorization. The resistance patterns are a bit worrying. This is specific. We are seeing high-level resistance to ampicillin, amoxiclav, ceftriaxone, and gentamicin to the access drugs. And when you look at Acinetobacter, you look at Kleb, you see these are among the categories of resistance profiles we managed to pull out to represent the worrying patterns of resistance. And then higher resistance rates to the watch antibiotics like ceftriaxone, the cephalosporins. Now you look at the piperacin, tazobactam, and the ciprofloxacin. These are classified as drugs under watch. They must be given as second alternative, but we have a lot of resistance. Then when you look at the last reserve, which should be the spared drugs, this is the resistance we are seeing, Acinetobacter. But most worryingly, you recall that WHO guides us that for any MRSA or Staphylococcus cause resistance, the last reserve is vancomycin. But you can look at vancomycin presenting a high level of resistance. So what does this tell us? We managed in our surveillance, we work with the academia. These are labs which are within the teaching hospitals, but under the Makerere University. We pulled out these results. It is anonymized for confidentiality, but you look at the patient was in ICU, but you look at, there is a high demonstration of pan-resistance, resistance to multiple drugs, including amikacin, including colistin, and the carbapenems. So this is the problem we are facing, colleagues, with resistance. Selectively, we also went into the quality issues. And the quality issues are telling us that more of capacity building sample collection, organisms from sterile samples by health facility. So we have gone into the data set and we pulled out of those isolates we have, which organisms were collected under aseptic means. So there is still a challenge that most of the samples we are having, they were not collected under aseptic means. So it is still a gap that we must demonstrate in capacity building. The two portions you're seeing, we wanted to look into the distribution of resistance by age. The two slides you see with the distribution, one of the other one was picked from the data that we did from the Fleming Fund Fellowship Collaborative Project. And you realize that resistance is overlapping across age group from 0, assuming day 1 of the neonate, to 100. So it's still a problem. It's not selective of age, but it overlaps. And then when you look on this slide, we concentrated on the data set we have from the national surveillance system, organism distribution by age category. You are seeing that from neonates, we all know neonates, and then you are looking at above 65 years. So the gram-positive and gram-negative organisms are distributed almost similar to the resistance pattern. And this is also very good information for us to know. Now, the proficiency test results for sites participating, these are the ones from the ECHO program coordinated by the National Microbiology Reference Lab. And this slide takes us into the understanding the test ordering practices. In one of the hospital, we studied patients, identification age, dietary intake, and all those aspects, sample collection, type of sample collected, type of tube additive, hemolysis, and all those. Storage, basically we are looking at the diagnostic stewardship, taking off the right sample, diagnosing the right patient, following the right procedure. We realized that 22% of these patients had completeness of the diagnosis and assessment, the cracking. And then having the right patient of all the data set we have, we had 41%, meaning that we still have to do more of capacity in getting the right diagnosis. And then the right test was 64%. And then correct timing. What do I mean by correct timing? You take off a sample before you administer an antibiotic. You know the implication of prior antibiotic administration of antibiotics prior to sample collection. Most especially the yield of the culture may be affected. So we need to do all this, but at least we know what is happening. When we go to the watch antibiotic classification, you know about the access antibiotics, you know about the reserve, and you know about the watch. To emphasize the importance of rational and optimal use of potential antibiotics for antimicrobial use and consumption, this is the category that all countries must follow as guided by WHO. So we went into this. This is also work done by our country grant implementers, the Infectious Disease Institute with the Ministry of Health, and quarterly surveillance of antibiotic use and consumption. 5 out of 9 targeted point prevalence surveys were conducted at regional referral hospitals, 9 regional referral hospitals. We realized that ceftriaxone and metronidazole infusion were the most prescribed, if you remember the previous slide on watch. And half of the prescription were based on AWARE classification. Half, that is something to underscore. So among the access, you have close to 50%. Among the watch, you have close to 44%. Reserve, and then there are those which are unclassified. For example, there are unclassified antibiotics, which were also more to a certain level prescribed. And now the annual antibiotic survey was done in June to June 2021, and average expenditure on antibiotics was 41%. All this puts into consideration of use, consumption of antibiotics, with over 60% of this expenditure being spent to procure amoxicillin, ceftriaxone, and metronidazole infusion. Now, when you go to the other side, you look at most worrying that 1% of prescriptions were based on culture and sensitivity results. So it means we have to do more of bridging the gap between the lab and the clinical team. If you have 1% of prescription based on culture and sensitivity, we still have a problem. This is work I'm presenting a preliminary slide from the MAPS study, which was done by the regional Fleming Fund ASLM support. And this study, this is preliminary results on AMU, considering the anatomical therapeutic class of drugs. It also underscored, because there was a retrospective review of the data among 16 government hospitals, penicillin with extended spectrum was most frequently consumed as anatomical therapeutic class A. And then top 4 and ATC classes accounted for over 88% of all AMCs, and top 5 consistent for all the 3 years. So this also tells us that even out of the independent study that was done, our overuse of penicillin, similar to available data for 2017, retrospectively was seen. So it also tells us that a lot is being done. Now, having seen all that, colleagues, we seem to be dealing with a wicked problem. Wicked in a way that it is very difficult to address, given the narrow pipeline of antibiotics that we have, narrow pipeline and a long process of coming up with new antibiotics. So it seems to be wicked, which we cannot control abruptly, but we may put in control measures to address AMR. And for us as Uganda, this is what we chose. The traditional way, perhaps, of solving complex problems, if we employ the waterfall approach by considering the whole of society engagement, we will collect data. It takes us time to have a solution, and then perhaps we can tame the problem. We gather data, we analyze the data. This is what we are doing. We formulate a solution, and then we implement a solution. This is what we are doing because we're already engaging with the data we have. We are engaging with a high level of ministry to address this by putting in measures and control, considering prevention first, controlling the access and sustainability of the gains with incremental targets for implementation. On top of that, we have our capacity building approach. Given what I have taken you through, we develop surveillance tools and indicators for us to do surveillance. And then that leads us to build skills and have that capacity to be able to do the right surveillance. And on that, we leverage on what is existing, partner support, government, and have that capacity in terms of staff, human resource, and infrastructure. But also, we emphasize the establishment of governance structures with clear roles, and then win the political will. And then being cognizant for us to achieve that of the local context of attitudes, adaptability to change, the policies, the strategies, and partnerships. Like now, we are working with partners, the regional partnership, to convey the country and all the specific synergies available. This is my last slide. We are looking at improving all this by critically analyzing and improving data, link AMR testing laboratories, the regional sentinel sites, including private, we are here to bring on board, with the NCC, and have a dashboard to coordinate all work for AMR. And then increase microbiology testing in all national, regional, and district hospitals. Provide the required microbiology supplies. That one we are working with government, ministry. Recruit the right HR, the clinical microbiologists at those levels, and provide the capacity building in microbiology skills, as well as demand creation for microbiology services. Demand creation is critical, and bridging the gap between lab. We also want to leverage on LIMS, Lab Information System, and also further leverage on the already existing structures. We have the structures defined for Ministry of Health. We don't need to reinvent the wheel, but we seek to plug into those existing structures and have AMR surveillance as holistically implemented. And then lastly, we embrace the One Health as holistic implementation approach. Specifically, we pledge that we are looking at making sector-specific needs under One Health, and also establish and strengthen those sector-specific NCCs to address AMR issues at sector level and departmental level. For example, in our Ministry of Health, we have the NCC in the lab. It is also ideal to have the same NCC as advised by WHO in the pharmacy department. So that is critical to follow up on the sector-specific issues of AMR. With that, I would appreciate the National Microbiology Reference Lab under the Central Public Health Laboratories, all within the Department of Labs, Ministry of Health, our funders, CDC, IDI, the country grant implementers for Fleming, Fleming Fund itself, ASLM, WAS, and MAPS for the support, and all of you in the audience. For God and my country, thank you very much.
Thank you very much. Thank you very much, Ibrahim, for that splendid delivery and presentation. It's been very informative, and it's also great to see how much effort is being put in from the governance level in Uganda to be able to steer the affairs relating to AMR. There are some very interesting realizations that come up to identify that we have up to 1%, if not less, of prescriptions being based on culture and sensitivity. Basically tells us that there is quite a lot of work that needs to be done. And thank you very much for highlighting that. We therefore also even know further that there is the need to put a lot more effort into the pre-analytical aspects of our surveillance activities so that we are sure we have the adequacy and completeness of data that is required to support the surveillance efforts. Thank you also for showing how well integrated Uganda is applying all the partner support efforts, integrating them to obtain the desired outcomes. So outcomes from MAP, outcomes from EQA, outcomes from other studies. I think the integration really is coming in quite well. And we have in from what we are looking at discussing today, how then are we able to translate all this data and not just have it as data, but have it as actionable items or real effects that come up. So thank you very much for those insights. And thank you again to Mary for showing us from a technical perspective what is happening in the world of children and how this also links to the implementation of Ghana's National Action Plan and how we can use this to inform policy. There are some interesting questions I would like to pick from the chat box. And the first one is to Ibrahim. I think there was a slide that spoke about a patient in the ICU that had some significant multi-drug resistance. Abraham Alabi would want to know how the cases of such highly resistant bacterial infections are handled in Ghana. Ibrahim, please. Hello, Ibrahim. Yes, Uganda.
Thank you very much. Yes, that's a very, very interesting question because patient handlers, the clinicians, the nurses, at some level are being puzzled. Most of these drugs, for example, the carbapenems, the high-end antibiotics, the reserve drugs, may not be as listed on the essential medicine list. So given this data we have, we're already in a high discussion with the Ministry of Health and the leadership to come up with approaches of how such patients can be managed. And one of the approach we are proposing is at least to avail alternatives to most of these drugs to such patients. And very soon such guidance is going to come out as we are going into the in-depth critical looking into our data and further advise ministry on how to address AMR. But particularly for such patients, that guidance is being discussed on how such alternative drugs, in case if you are a patient in ICU and you need alternatives given the available resistant, to increase on the availability of such as essential medicine list. Over.
Thank you very much, Ibrahim. And I think this comes at a very opportune time for all countries to consider. There was a similar case from Kenya where there was an infant that demonstrated a similar situation. And so as countries are looking at these, it will be important to prioritize the efforts at these guidance. There is another question here. I think this would go to Mary Magdalene from Lawrence Kachule. Any explanations to having more antimicrobial resistance in under 5 as compared to other older group categories? Is there any explanation why there are such observed differences in antimicrobial resistance? Mary, if you could offer yes.
Thank you very much. Thank you very much for the question. I don't have any research on the adults to know the current antimicrobial resistance levels, but to answer his question, I will say that in Africa, most of these daycare centers are overcrowded. We have children that are overcrowded, and the possibility of transmitting these pathogens that may contain microbial drug resistance are possible. So it may be one of the things that is accounting for the high prevalence of antimicrobial drug resistance in children in the daycare centers. Thank you.
All right. Thank you very much, Mary, for that response. And maybe we'll take the last round of questions. And I believe this would go to Ibrahim. The work in Uganda has been very impressive, also focused on ensuring quality of work related to AMR surveillance. How, in your opinion, can the impact of all the interventions carried out be measured as demonstrated on the effectiveness of the interventions that have been put in place, taking Uganda as a case study?
Thank you very much. How, in my opinion, is understanding AMR and its complexity in terms of management. It requires a holistic approach. Holistic approach at sector level and a holistic approach at multi-sector level. But countries should begin with what they have, because investing in AMR is quite huge. So it requires to begin with what is available and do that as you are learning lessons to improve. So in our approach, that is the approach we take. We cannot say that we have done it all. There is a lot of gap to do in terms of training, in terms of capacity. But the issue is have integrated efforts and approaches to addressing AMR as a public health approach. Over.
Okay. Thank you very much, Ibrahim. That was very much appreciated. All too soon, colleagues, today's session is drawing to an end. We would like to thank you very much for making time for this COP session. And we look forward to meeting you again at the next session that comes up very soon. There is a poll that is currently ongoing, and we would very much encourage colleagues to respond to this satisfaction poll, just so that we have feedback as to how we can improve upon the AMR COP sessions that we have. So As you see the pop-up on your screen, please do well to respond to support this activity. The next AMR CoP session would come off in 2 weeks. We hope that everyone will join and we have another yet impactful event. We are happy to also inform that opportunities are open to all who have experiences, research works, etc., like what we have seen, to share these on this AMR CoP platform. For all who are interested in taking advantage of this opportunity, there is a flyer that is circulating on the various CoP platforms. You could find that and receive the details even further. Or you could send an email to eqaafrica@aslm.org. My colleagues will place that email in the comment section so that it's available to us. You could send an email and somebody would certainly get back to you and guide you as to how this can be made possible. Thank you very much once again. For those who have made inquiries for the resources in this session, they would be available on the ASLM Resource Center. So once they are put up, you would be able to access them from the ASLM Resource Center for your reference purposes. Thank you very much, Mary Magdalene, Osei. Thank you very much, Mugerwa, Ibrahim, for the presentations. Thank you all colleagues for joining this session. And we look forward to having you once again at our next AMR CoP. Have a wonderful rest of the day and have a pleasant week. Bye for now.